women can lower their risk of developing breast cancer. So what are some of the things that we can do? You can get to and stay at a healthy weight by exercising. And remember, your weight is controlled by three things actually. I was going to say two, but it's three things. One is your intake. Your intake is actually it is responsible for 80 to 90% of your weight. Physical activity is responsible for only 10 to 20% of your weight. So if you're exercising, every day of the week, 5 hours a day, and you're still eating what you shouldn't eat, you're going to remain obese. And then of course the last thing is genetics. So being physically active, what is recommended is 150 minutes of moderate intensity activity or 75 minutes of vigorous intense activity. So moderate intensity activity is like a brisk walk, and that should be broken up. So the 150 minutes is spread throughout the week. It's not recommended that you bunch it all in 1 or 2 days, but rather you spread it out through multiple days. And then vigorous activity is anything that makes you sweat, like running on the treadmill or or jogging. And then of course limiting or avoiding alcohol use is also key in lowering one's risk of breast cancer. Like I said, breastfeeding, if you breastfeed, you are protected against the aggressive triple-negative breast cancer that preferentially affects black women, and also not using hormone replacement therapy to combat the symptoms of menopause is key in lowering your risk of breast cancer. Now, there's some women who are at particularly higher risk than the general population, and these are women such as Angelina Jolie, who have the known mutation in one of the genes that causes breast cancer. That's called the BRCA1 or BRCA2 genes. And there are also some other individuals who are at a very high risk who are not known to have genetic mutations. These are people that have a very extensive family history of breast or ovarian cancer in multiple first and second degree relatives. You might know some people who have many of their sisters, their mother, their grandmother, their cousins having breast cancer. For such very high risk women, there are some medications that can actually be given called chemopreventive medications to reduce their risk of developing breast cancer. And also, if you are at a very, very high risk, sometimes we do recommend that patients undergo prophylactic, so that's preventive bilateral mastectomies, removing their breast. And this can lower the risk by about 98%. That risk doesn't go to zero because there's always a little bit of breast tissue that's still on the chest wall that can never be taken off completely. And then also, if people have completed childbearing and they are at a very high risk, they can consider removing their ovaries, because the ovaries are not being used anyway. That can lower the risk by about 50%, even if you don't remove your breasts. So, like I said, there's absolutely no sure way of preventing breast cancer, but there are things that all women can do that might reduce their risk of developing breast cancer. And there are also some strategies that we can do that might increase the chance that if you do develop breast cancer, it's detected very, very early when it's most curable. And so this brings me to screening. So why do we screen for diseases? We screen for diseases that are common, where we know that we can make an impact. So like I said, breast cancer is very, very common all over the world. 1 in 8 women will get breast cancer. And so we screen for breast cancer because you would have to screen 8 women to save 1, which is cost effective. We don't screen for diseases that are very rare because it's not cost effective. For instance, brain cancer is very, very rare. It happens, less than 1 in 1,000. So in that situation, you would have to screen 1,000 people to pick up 1. So there's no screening for such a disease. The other reason why we screen for breast cancer is that it can be very deadly. In women, it's the second leading cause of cancer-related deaths, second only to lung cancer. And then, of course, we know that if breast cancer is detected early, because it's still contained in the breast, and the breast is not a life-sustaining organ, it can be fully cured. So these are the most recent updated screening guidelines from the American Cancer Society, which essentially is the body that the whole world follows. And previous to the new recommendations, the blanket recommendation was that all women should start screening mammograms once they hit the age of 40. And so right now they've changed those recommendations to 45 to 54. Women should get screening mammograms once a year. And over the age of 55 and beyond, the mammograms should be done every other year as long as a woman is in good health. For instance, if a woman is 70 years old and she has multiple comorbidities, multiple other medical problems like diabetes, hypertension, she's had a stroke, she's in a wheelchair, it doesn't make sense to screen for breast cancer because there are other more serious diseases that are competing for her life. So as long as a woman is in good health, the screening will continue. Once the health of a woman is failing and there are other more serious diseases, screening stops. There's also a clause in there that you can still start screening mammograms at the age of 40 if you so desire. And so what we're recommending is that all women should still should start screening mammograms once they hit the age of 40. So clinical breast examination is the second way, and this is something that is particularly relevant to our community because this is a low to middle income setting, and screening mammograms are not available for everybody because of the cost and availability. So there's currently research that is going on to determine if clinical breast examination can be a low-cost option for this kind of environment. The results are not available yet, but the preliminary results show that those people who are in the screened group, screening with clinical breast examination, present with less advanced cancers than those women who are unscreened. And so what is a clinical breast examination? This is when a medical professional, a nurse, a paraprofessional, or a doctor administers a physical examination on a woman's breast to detect any abnormalities. And the recommended schedule is every 3 years for women in their 20s and 30s, and once a year for women in their 40s. And so if you're going to your family doctor, your family physician, practitioner for anything, ask them to do a clinical breast examination on you just to check around the breast. The third modality is breast self-examination. So I've actually listed this as breast self-awareness because we don't call it breast self-examination anymore, because research has shown that it really doesn't impact the clinical outcome of patients with breast cancer. It doesn't really change mortality. But what it does is that it actually empowers women to take responsibility for their own health, so that so that all women in general should know how their breasts feel, so that if there's a change, you can bring this to medical attention. So it's not really used as a screening tool anymore, but more for raising awareness. And so what we recommend is that you feel around your breasts once a month. You pick the same time every month, maybe the first of the month, the middle or the last. Just kind of feel around the breast so that you know exactly what your breast, so that this is not normal for you. You can now bring that to medical attention. And I'll go into a little bit more detail about clinical breast examination and self-breast awareness in a little bit. So what is a mammogram? This is the recommended tool to screen the average woman, the population for breast cancer. So a mammogram basically is a special X-ray of the breast. So what happens is that there are two plates here. So this is the machine, and there's a plate underneath and a plate on top, and the breast is kind of pulled into that into the bottom plate and spread, and then it's compressed. It's not painful, it's just a little bit uncomfortable. It takes probably less than 10 minutes. Once the breast is compressed between those two flat plates, the picture is taken and sent to the radiologist, and that picture on the the spread out breast, the radiologist can see any abnormalities in the breast. And this is the picture of what the mammogram looks on imaging once it's all spread out. So sometimes we consider breast MRI for patients, again, who are at a very high risk, say for those patients who have multiple family members with breast ovarian cancer, or perhaps are known to have one of the mutated genes. And so what we recommend is that it's not in place of a yearly mammogram, but it's in addition. And so we recommend both an MRI and a mammogram either once a year or one of the strategies every 6 months to keep a very close eye on the woman. And so an MRI scan, instead of using conventional X-rays that a mammogram uses, it uses magnets and radio waves to make more detailed cross-sectional pictures of the entire breast. The problem with MRI and why it's not recommended for everyone is because of 3 things. Number 1, it's expensive. Number 2, it can require contrast to be injected into the woman so that they see the pictures better. And then number 3, it's very, very sensitive. So what it does is that it can find a lot of things in the breast that end up not being cancer. And so what we've seen with women getting MRIs is that more often than mammograms, those women are called back for abnormalities on their MRIs, and they end up needing more unnecessary biopsies for things that turn out not to be cancer. So that's what we call recalls and unnecessary biopsies. That's the reason that MRIs are not done for everyone. So again, a clinical breast examination, like I mentioned, is an examination of your breast by a healthcare professional. And this is just a picture of, how it's done. So you lie down and basically somebody just feels around, feels the breast, feels the armpit, make sure everything feels normal. And this is what can be picked up by a trained clinician. A trained clinician can pick up a mass of less than 1 centimeter, even down to half a centimeter, while somebody that is untrained, if you're not trained, the patient can probably pick up a lump that is probably about 2 centimeters. So that's why we recommend clinical breast examination, because they can pick up tumors that are much smaller than you can pick up yourself. So the breast self-exam, this is again a technique that allows you to look at your breast, feel your breast for any physical or visual changes. So it's done in 2 positions. So lying down, you use the 3 middle fingers, 1, 2, and 3, and you sort of divide the breast into 4 quadrants, and you do a circular motion, kind of going up and down on each of the 4 quadrants. When you're done with 1 quadrant completely, you move to the next quadrant, the 3rd quadrant, and the 4th quadrant, and then you also feel the nipple areola area. So you do that lying down, and then you stand up, you look in the mirror, you put your hand behind on your hips like this, and make sure that your breasts look normal, that there's no pulling in, what we call retraction, there's no skin changes that you didn't see before, and then also you feel inside your armpit for hard lumps, because when breast cancer spreads, it always starts in the breast, and then the first place it goes to before spreading to other parts of the body is the armpit. And so there are actually some patients, particularly patients who have these aggressive forms of breast cancer, that may have a very, very small lump inside the breast that is not felt, which can actually spread to the lymph nodes in the armpit. So that's why we recommend that during your monthly breast self-awareness, you also feel in your armpit for lumps and bumps as well. And of course, if you have a lump in there, don't ignore it. Present to your healthcare provider for further action. So this is what you should be looking for. Skin changes, like a rash, or hard lumps on the skin that were not there before. Redness also, we're dark colored, but you might still see that the skin of the color of the breast is not what it was before, and perhaps darker than the other breast. Also look for nipple dripping or nipple discharge. This is of course in somebody who is not lactating, somebody who is not breastfeeding. If you're seeing bloody nipple discharge, that needs to be evaluated. So bloody or milky nipple discharge in a woman who is far from breastfeeding needs to be evaluated. if you're seeing skin dimpling. So what we call is, a dimple that is the skin of the breast is kind of pulled in or retracted, or looks like an orange peel appearance. An orange peel is very dimpled. That definitely is a cause for concern. That needs to be evaluated. If your nipple was normal before, it was an outward appearing nipple, and now becomes retracted or pulled in, that may be a cause for concern, because sometimes what happens is that there's a tumor behind the nipple that is retracting and pulling on the nipple. And of course, the commonest thing we hear about is a lump. But again, not all breast cancers present as a lump that you can feel. There are many other changes that we need to be looking for as well. So, having said that, again, particularly for the more developed world, where patients are getting screened every year or every other year, majority of patients do not have any symptoms and can't even feel a lump. It is very possible for somebody to not feel a lump and still have breast cancer. And that's why in our clinics where we see these very early stage breast cancer patients, it's a very, very devastating disease, because the woman, essentially goes for her screening mammogram on her lunch break or on her way home. She feels well, doesn't have any problem going on, and then she's told she has something abnormal on the mammogram. Next thing she knows, she's getting a biopsy. Next thing she knows, she's told she has breast cancer. Next thing, she's in my office, I'm telling her she's going to need chemotherapy. She's going to feel sick for several months. She's going to lose her hair. So it can be associated with a lot of anger, a lot of denial, again, because the majority of these patients with early stage breast cancer really don't have any symptoms at all. Some patients, particularly those patients in our communities who are not screened, usually present with abnormalities. Again, these are lumps that can be felt in the breast or armpits, nipple changes like I mentioned on the other slide, and skin changes as well. And then if a patient has systemic symptoms, and what I mean by systemic symptoms are symptoms in other parts of the body, so like a cough or chest pain, shortness of the breath, which doesn't go away with a couple of rounds of antibiotics, that could be a cause for concern. If there's a new bone pain somewhere, so not the usual arthritis that we all have every now and then, but if there's a worrisome bone pain, and the trick to cancer symptoms are that those symptoms are persistent and progressive. If the symptoms are getting worse with time, they're not going away with treatment, that is a cause for concern. So the areas that breast cancer likes to go are particularly the lungs, and it's in that situation, if there's spread to the lungs, there could be cough, chest pain, shortness of breath. The liver sits in the right upper quadrant of the abdomen. So if there's pain in the right upper quadrant of the abdomen here, or if there's nausea or vomiting or unintentional weight loss, you're losing weight and you're not trying to lose weight, but the weight is coming off despite your eating and not increasing your physical activity, that may be a cause for concern. Breast cancer also likes to go to the bones. So like I mentioned, if there's a new bone pain, which is persistent and progressive, it needs to be checked out. And then also breast cancer likes to go to the brain. And symptoms of cancer in the brain are headaches, particularly headaches that wake you up early in the morning, or nausea, vomiting. There could be weakness in any extremity, so maybe weakness in the arm, or weakness on the leg, or weakness on one side of the body that could mimic symptoms of a stroke. This could indicate brain metastases. So what do you do if you find a lump? So first thing, I always tell people is you need to, calm down, take it easy, don't get all frazzled, but definitely plan a strategy. And why is that? Because actually most lumps are not cancerous. There are many, many things that can cause lumps in the breast. There's something that I mentioned earlier called a breast mouse or a fibroadenoma, which is very, very common, particularly in younger people who are still menstruating. That doesn't have any malignant potential. It's not cancer. There are cysts that are very common in multiple different women. There's a fibrocystic disease of the breast that can be seen in people who take a lot of tea or coffee that has caffeine in it. There could also be infections. There are a myriad of things that can cause breast lumps that are not cancer. But having said that, even though most breast lumps don't end up being cancer, every single breast lump needs to be absolutely evaluated because there's always a chance for breast cancer. So the second thing you should do is seek medical attention. You should go to your family doctor or go to a general surgeon, because what you would need if you have a lump is you would need first proper imaging tests. Because for instance, if one has a lump and you get a mammogram, a fibroadenoma, which is a benign breast lump, looks very different than how a breast cancer looks. So if you have a mammogram, there are certain characteristics that benign lumps have, which are very different from the first step is usually a mammogram. And then if the mammogram comes back looking suspicious, a needle biopsy usually needs to be done to determine exactly what the lump is. Starting from the age of 40, for 2-3 decades, that amount of radiation is not enough to cause breast cancer or any cancer. The next is you can be too young or too old to get breast cancer. Unfortunately, everybody is at risk. While the risk increases with increasing age, I mentioned that the average age or the median age is about 62. My youngest breast cancer patient personally was 19 years old, and my oldest patient now, who is still alive and in my practice, is 93 years old. So nobody is too young and nobody is really too old. You won't develop breast cancer unless it runs in the family. So the hereditary form of breast cancer just accounts for 10% of all breast cancers, and 90% of breast cancers are what we call sporadic. They don't come in a family that has lots of breast cancer in them. So even though nobody in your family has had breast cancer, ovarian cancer, or any cancer, that's not a reason why an individual is immune from breast cancer. Underwired bras don't cause breast cancer. Antiperspirants, hair dyes, deodorants, dairy products like milk or cheese, caffeine, hair relaxers, straightening the hair, cell phones being put in the pocket near the breast, none of these things, they've actually looked at trials and they've done studies, and all these things are completely false. People with breast cancer always find a lump. That's not true. And like I said, there are many breast cancers that don't present as a lump, particularly if it's early stage disease. There's also another very aggressive form of breast cancer called inflammatory breast cancer, where the breast looks very hot, warm, it's swollen, it looks like a very nasty infection. This doesn't have a lump that you can feel, the whole breast is just abnormal. That's inflammatory breast cancer and it's not a lump. If surgery is done, this is a very common one. Once you open somebody up, the cancer just explodes and spreads all over. That's an old wives' tale. Surgery to cut out cancer doesn't cause cancer to spread. There's only one kind of cancer, and I think it probably came from that cancer, kidney cancer. There's a special kind of clear cell cancer of the kidney that we don't do biopsies for because it can actually track. That's really the only cancer. And then testicular cancer, we don't do biopsies because it can track and lead to seeding of where the biopsy needle. But other solid tumors, breast cancer, colon cancer, head and neck cancer, cervical cancer, if you cut them out, they do not spread. It's if you leave them in the body and don't cut them out, that is when eventually they spread to other parts of the body and kill. And then the last one I wanted to mention is that men don't get breast cancer. Men also get breast cancer. It's just much, much less common in men. So for women, it's 1 out of 8 worldwide. For men, it's about 1 out of 1,000. So men also do get breast cancer, particularly if they've had, a bad gene passed from family, from their parents, or if they have certain other conditions like cryptorchidism or gynecomastia. There's certain things that can lead to male breast cancer as well.